Imagine this. You walk into your doctor's office feeling perfectly fine. No pain, no complaints, nothing wrong. But your doctor orders a routine screening, just to be safe, they say, and suddenly you're staring down a diagnosis, a biopsy, maybe even surgery. 6 weeks later, you're recovering from a procedure you never actually needed, dealing with side effects that are now worse than whatever that screening supposedly found. Sound far-fetched? It happens to thousands of seniors every single year in the United States. And today, I'm going to walk you through 5 medical checkups that many leading physicians and major health organizations say you should seriously reconsider or skip entirely after the age of 60. Now, before we go any further, let me be absolutely clear about something. This video is not anti-medicine. This video is not telling you to stop seeing your doctor. What this video is about is a growing conversation happening right now among top researchers, geriatric specialists, and institutions like the United States Preventive Services Task Force, the USPSTF for short, about something called overdiagnosis and overtreatment. Those are fancy words for a simple idea. Sometimes a medical test finds something that looks scary on paper, but would never have caused you a single symptom, never shortened your life by a single day. And yet, once it shows up on a scan or in a blood result, the medical system kicks into gear. More tests, more appointments, more procedures, more anxiety, and for seniors especially, people whose bodies recover more slowly, who face higher risks from anesthesia, infection, and surgical complications, that cascade of treatment can do far more damage than the thing it was supposedly catching. So today, we're going to look at 5 specific checkups where the science increasingly says, for many people over 60, the risks outweigh the benefits. I'll explain why each one made this list, what the research actually shows, and what you should talk to your own doctor about. Because being informed isn't the same as being reckless. Being informed is how you protect yourself. Let's get into it. Number 1, and this might be the most controversial one on the list, is the PSA blood test for prostate cancer in men over 60 and especially over 70. PSA stands for prostate-specific antigen. It's a protein made by both normal and cancerous cells in the prostate gland, and for decades, doctors used a simple blood draw to measure your PSA level. If the number came back high, the assumption was that cancer might be lurking, and the next step was usually a biopsy, a procedure where a doctor inserts a needle through the rectal wall to collect tiny samples of prostate tissue. If you just winced hearing that description, you're not alone. It is exactly as uncomfortable as it sounds, and it carries real risks of bleeding, infection, and in some cases, sepsis, a potentially life-threatening blood infection. Here's the problem. A high PSA number doesn't necessarily mean you have cancer. Enlarged prostates, incredibly common in older men, can raise PSA. So can infections. So can riding a bicycle the day before the test, believe it or not. The test throws false alarms constantly. One major study published in the New England Journal of Medicine followed thousands of men for over a decade and found that for every 1,000 men screened with PSA tests, roughly 1 life was saved from prostate cancer death. 1. Meanwhile, dozens of those same men underwent biopsies they didn't need. Others were diagnosed with slow-growing cancers that never would have caused them trouble, yet they went through radiation, surgery, or hormone therapy that left them dealing with incontinence, erectile dysfunction, and chronic fatigue. Dr. Richard Ablin, the man who actually discovered the PSA antigen back in 1970, wrote an op-ed in the New York Times calling the widespread use of his own discovery, and I'm quoting him here, a public health disaster. That's the inventor of the test saying we've misused it. Now, does that mean no man should ever get a PSA test? No. If you have a strong family history of aggressive prostate cancer, a father or brother diagnosed young, particularly African American men who face statistically higher rates, a conversation with your doctor about targeted screening might make sense. But routine, annual PSA screening for men in their late 60s and 70s who have no symptoms and no family history. The USPSTF, the American Academy of Family Physicians, and numerous urology organizations have all moved toward recommending against it in that population. The reason is simple math. Most prostate cancers diagnosed in elderly men are slow-growing. They are, as doctors sometimes phrase it bluntly, something you die with rather than something you die from. The danger isn't the blood draw itself. The danger is what comes after. The biopsy, the anxiety, the treatment for a cancer that was never going to hurt you. And every one of those interventions carries real physical costs that hit harder when you're 65 or 75 than when you're 45. So what should you do instead? Talk openly with your doctor. If you're experiencing actual urinary symptoms, difficulty starting urination, frequent nighttime trips to the bathroom, blood in the urine, absolutely get evaluated. Symptoms deserve investigation. But a routine PSA screen with no symptoms, no risk factors after a certain age, that's exactly the kind of checkup that the medical community is pulling back on, and you deserve to know why. Number 2. Routine screening colonoscopies after the age of 75. Now, I can already hear some of you saying, wait a minute, my doctor told me colonoscopies save lives. And you're right. Colonoscopy screening has been one of the genuine success stories in cancer prevention. Catching colon polyps early, removing them before they turn malignant, that process has prevented thousands of colorectal cancer deaths. Nobody is disputing that. But here's what often gets lost in the conversation. Screening guidelines were designed with a specific window in mind. The USPSTF recommends routine colorectal cancer screening for adults starting at age 45 and continuing through age 75. After 75, the recommendation shifts. For adults between 76 and 85, the task force says screening should be an individual decision, not automatic, not routine, but a careful conversation between patient and physician. And after 85, they recommend against routine screening entirely. Why the cutoff? Several reasons stack on top of each other. First, the prep itself. Anyone who has done a colonoscopy prep knows it's miserable. You're drinking large volumes of laxative solution, spending hours in the bathroom, becoming significantly dehydrated. For a healthy 50-year-old, that's an unpleasant day. For a 78-year-old with kidney issues or heart disease, dehydration can trigger dangerous electrolyte imbalances, dizziness that leads to falls, and in some documented cases, acute kidney injury. The prep alone lands elderly patients in the emergency room more often than most people realize. Second, the procedure carries perforation risk. That's a small tear in the colon wall. Overall, the risk is low, roughly 1 in every 1,000 to 2,000 procedures. But that risk climbs with age, and if perforation happens to an 80-year-old, the emergency surgery required to repair it carries mortality rates that make the math very different than it does for a younger patient. Third, and this is the factor people think about least, colon cancer typically grows slowly. We're talking 10 to 15 years from the first abnormal polyp to a cancer that threatens your life. If you had a clean colonoscopy at 72 and you're now 77, the likelihood that a brand new dangerous cancer has developed and reached a threatening stage in that 5-year window is statistically very small. Meanwhile, the procedural risks have gone up because your body is 5 years older. If you're over 60 or caring for an elderly loved one, this information could genuinely change how you navigate the next doctor's appointment. Consider sharing this video with someone in your family who might benefit from hearing it. So what's the alternative? Stool-based tests. The FIT test, fecal immunochemical test, is a simple at-home kit that detects hidden blood in stool. It's painless, requires no prep, no sedation, no hospital visit, and it's quite effective at flagging problems that actually need investigation. For many seniors over 75, a yearly FIT test provides meaningful surveillance without any of the procedural risks. If the FIT comes back positive, then your doctor can make a case for a diagnostic colonoscopy, one driven by evidence rather than a calendar reminder. That distinction matters. A diagnostic procedure prompted by actual findings is very different from a routine screening performed on autopilot. Number 3 on the list, routine annual electrocardiograms, commonly called EKGs, for people who have no heart symptoms whatsoever. An EKG records the electrical activity of your heart through small electrode patches placed on your chest. It takes about 10 minutes, it doesn't hurt, and it sounds like the kind of test that couldn't possibly do harm. What's wrong with checking, right? The problem isn't the test itself. The sticky pads don't hurt you. The readout doesn't hurt you. What hurts you is the chain reaction that a borderline or falsely abnormal result sets off. EKGs in asymptomatic older adults are notorious for producing findings that look worrying but mean nothing clinically. Minor rhythm variations, slight conduction delays, non-specific ST changes. That's medical language for a squiggly line on the readout that doesn't look textbook perfect but isn't actually dangerous. The older your heart, the more electrical quirks it accumulates. A 70-year-old's EKG almost never looks like the pristine tracing in a medical school textbook, and it isn't supposed to. But when a doctor sees those minor abnormalities, they face pressure. Legal pressure, institutional pressure, sometimes just psychological discomfort, to investigate further. So now you're referred for a stress test. The stress test looks slightly off because, again, you're 70 and your heart has been beating for over 2.5 billion cycles. So they order a cardiac catheterization, a procedure where a thin tube is threaded through a blood vessel in your groin or wrist all the way into your heart. That procedure carries risks of bleeding, blood vessel damage, stroke, and in rare cases, heart attack, the very thing it was looking for. A landmark study published in the Annals of Internal Medicine examined over 1,000 asymptomatic patients who received routine EKGs during annual physicals. Researchers tracked what happened afterward. A significant percentage of those patients ended up undergoing additional cardiac testing, imaging, stress tests, specialist referrals that generated tens of thousands of dollars in medical costs. And the number of actual cardiac events that were caught and meaningfully treated earlier because of those routine EKGs? Essentially zero compared to the group that wasn't screened. The USPSTF has stated clearly that there is insufficient evidence to recommend routine EKG screening in asymptomatic adults at low risk for coronary heart disease. The American College of Cardiology has echoed similar caution, warning specifically against annual EKGs as part of a standard checkup when the patient reports no chest pain, no shortness of breath, no palpitations, no fainting episodes. If you feel something wrong, chest tightness walking up the stairs, a fluttering sensation that makes you dizzy, unexplained breathlessness when you're lying flat, an EKG is absolutely warranted. Symptoms change everything. Symptoms are your body raising its hand and saying something needs attention. But an annual EKG performed on a Tuesday because your calendar said it was time, that's a fishing expedition. And in older adults, the fish it catches are almost always red herrings that lead you somewhere you don't want to go. Number 4, and this one is specifically for the women watching, Pap smears after the age of 65. The Pap smear has been one of the most successful cancer screening tools in medical history. Since its widespread adoption, cervical cancer rates in the United States have dropped by more than 60%. That is a staggering achievement, and it happened because regular screening catches abnormal cervical cells early, long before they become cancerous. But here's what many women don't realize. Every major guideline-setting organization, the USPSTF, the American Cancer Society, the American College of Obstetricians and Gynecologists, agrees on this point. If you are over 65 and you have had consistent normal Pap smear results throughout your screening history, you can stop. The screening has done its job. Cervical cancer is caused almost exclusively by persistent infection with certain strains of human papillomavirus, HPV. That infection typically occurs decades before any cancer develops. If a woman has been regularly screened through her 40s, 50s, and into her early 60s with consistently normal results, the probability of a new HPV infection progressing to cervical cancer after 65 is extraordinarily low. The math simply doesn't support continued screening in that population. And yet, millions of women over 65 continue receiving annual Pap smears because nobody ever told them they could stop. Their doctors order the test out of habit. Insurance pays for it, so nobody questions it. And occasionally, just like with the EKG scenario, the test returns a vaguely abnormal result. Maybe some atypical cells caused not by HPV, but by the natural thinning of vaginal tissue that happens with menopause, a condition called atrophic vaginitis. It's completely benign. But the abnormal result triggers a colposcopy, a procedure where a doctor examines the cervix under magnification and takes biopsies. The biopsies cause cramping, bleeding, and anxiety while the woman waits for results. And in the vast majority of cases in this age group, those results confirm what a more cautious approach would have predicted from the beginning. Nothing dangerous was ever there. There are exceptions. Women who were previously treated for cervical precancer or cancer should continue surveillance as their oncologist recommends. Women with compromised immune systems, organ transplant recipients on immunosuppressive drugs, for example, face different risk calculations, and women who were never adequately screened during their earlier decades may benefit from a catch-up screening conversation. But for the average 67-year-old woman with a history of normal pap smears, the guidelines are unambiguous. You've done your due diligence. This is one checkup you can cross off the list with confidence. And number 5, the one that might surprise you most, full-body CT scans marketed as preventive health screening. You've probably seen the advertisements. They show up in magazines, on social media, on billboards near strip malls. Get peace of mind, full-body scan, detect cancer, heart disease, and aneurysms before symptoms start. Some clinics charge anywhere from $500 to several $1,000s for these scans, and they market heavily to older adults who are, understandably, most concerned about hidden health threats. Here's what those slick advertisements don't tell you. A full-body CT scan delivers a significant dose of ionizing radiation, roughly the equivalent of several hundred chest X-rays in a single session. Radiation exposure is cumulative over a lifetime, and while a single scan probably won't cause harm on its own, repeated scans absolutely increase cancer risk. The very test marketed as a cancer detector is, in measurable terms, a cancer contributor. But the radiation isn't even the biggest problem. The biggest problem is what the scan finds, and it will find things. In virtually every person over 60, a full-body CT scan will reveal nodules, cysts, densities, calcifications, and other so-called incidentalomas, a real medical term for unexpected findings that show up incidentally and almost always mean nothing. A tiny nodule on the lung, a cyst on the kidney, a thickened adrenal gland. Each one of these findings looks potentially sinister on a radiology report, but is, statistically speaking, overwhelmingly benign. The trouble is that the word potentially turns your life upside down. That tiny lung nodule triggers a follow-up CT scan in 3 months, then another in 6 months, then maybe a PET scan, then possibly a needle biopsy where a long needle is inserted through your chest wall into lung tissue. A lung biopsy can cause a pneumothorax, a collapsed lung, in roughly 1 out of every 20 to 25 procedures. Now you're in the hospital with a chest tube because of a nodule that was going to sit there harmlessly for the rest of your natural life. The American College of Radiology, the American Medical Association, and virtually every evidence-based medical organization have recommended against full-body CT screening in asymptomatic individuals. These scans are not covered by Medicare precisely because the evidence does not support their use as a preventive tool. The clinics offering them operate on a cash pay model, and they profit regardless of whether the scan helps you or sends you down a rabbit hole of unnecessary procedures. If your doctor, based on your specific symptoms and risk factors, orders a targeted CT scan of a particular body region, your chest, because you have a persistent cough and a 40-year smoking history, for instance, that's evidence-based medicine at work. Targeted imaging prompted by clinical reasoning saves lives every day. But walking into a strip mall clinic and paying out of pocket for a head-to-toe radiation bath because an advertisement promised peace of mind? That's marketing dressed up as medicine, and it preys disproportionately on the fears of older adults. So let's bring it all together. 5 checkups that many leading health authorities say you should seriously reconsider after 60. Routine PSA testing. because the false positives lead to biopsies and treatments that often cause more suffering than the slow-growing cancers they find. Screening colonoscopies after 75, because the PrEP risks, perforation risks, and the slow growth rate of colon cancer shift the math away from benefit. Annual EKGs with no symptoms, because the minor age-related findings on the readout trigger invasive cardiac workups that almost never reveal anything actionable. Pap smears after 65 with a history of normal results, because the screening has already done its job and continuing it generates false alarms from benign tissue changes. And full-body CT scans sold as preventive screening, because the radiation exposure and the avalanche of incidental findings create far more problems than they solve. The common thread running through all 5 of these is something every senior deserves to understand. More testing does not automatically mean better health care. Sometimes more testing means more anxiety, more procedures, more recovery time, more complications, and more money spent, all without adding a single healthy day to your life. The best thing you can do is have honest, unhurried conversations with your doctor. Ask questions like these. What happens if this test comes back abnormal? What's the next step, and what are the risks of that next step? Ask, if we find something, would treatment actually change my outcome at my age? And perhaps, most importantly, what happens if we don't do this test? A good doctor will welcome those questions. A good doctor will sit with you in that conversation and help you weigh the genuine trade-offs rather than defaulting to, let's just check everything. You have earned the right to make informed choices about your own body, and that starts with knowing which screenings are working for you and which ones might be working against you. Take care of yourself. Move your body. Eat the foods that make you feel strong. Stay connected to the people you love. Sleep well. Laugh often. And when it comes to medical tests, remember, the smartest patient isn't the one who gets every test available. The smartest patient is the one who asks the right questions before the test is ordered. If this video gave you something to think about, go ahead and hit that subscribe button. We put out new senior health content every week designed to help you navigate these decisions with clarity and confidence. Share this video with a friend, a spouse, a son or daughter who might find it useful, and drop a comment below. I'd love to hear from you. Have you ever had a test that led to more stress than answers? Your experience might help someone else watching right now. Stay well. I'll see you in the next one.